All right, I'd like to welcome everyone today. Thank you for joining us for today's webinar. My name is Lauren Schwartz, and I am the program chair of the PA Association of Pathologists, and we are super excited you're here. Today, we are presenting diagnostic challenges associated with pleomorphic sarcomas, presented by Dr. Kosivi Dante. Just a little housekeeping before we get started. Everyone's mics have been muted and will remain muted during the webinar. If you have any questions at all during the presentation, please type them into the Q&A box located in your lower toolbar. I will bring them up at the end of the presentation, and we will get to as many as we can during our Q&A session. If you need technical assistance, please type into the chat box and someone will help you. Today's webinar will be recorded for training purposes. We'll have the talk from 12 to 12:45, and then we'll have about 15 minutes of questions. CME is available for this talk, and you can read the slide. Dr. Dante has nothing to disclose. And you can also look, this is how you're going to get your CME. Again, most of this will be done following the webinar around September when we're done with all of the webinars. So now I'm going to introduce our speaker, Dr. Kosivi Dante. Received his anatomic pathology and clinical pathology residency training in Burlington, Vermont at UVM, and completed 2 fellowships, one in bone and soft tissue pathology and another in cytopathology at UPMC in Pittsburgh. Since July of 2017, he has been a staff pathologist at the Allegheny General Hospital, where he practices cytopathology and surgical pathology. His interests include bone and soft tissue pathology, cytopathology, and quality and patient safety. Now, without further ado, we will turn the time over to Dr. Dante.
Thank you, Dr. Schwartz. Thank you for this wonderful introduction. Before I start, I would like to thank the Pennsylvania Association of Pathologists for giving me the opportunity to be part of this virtual seminar. Today, I want to talk to you about pleomorphic sarcomas. But first, allow me to start with a case presentation. This is a 69-year-old woman who presented with a groin mass. 2 months prior to presentation, she fell, and examination noticed a lump in her right groin. Ultrasound was performed and revealed a 3.8 centimeter lesion.
Dr. Dante, will you share your screen? We're unable to see your screen.
Oh, hold on.
Thank you.
Hold on here. I apologize. Okay. Can you see it now? Can you see it?
No.
Not sure what's going on here. Hold on.
Jessica or Jason,
hold on. I'm doing it now. Okay, I got it. Okay. What about now? Can you see it?
It's coming. Yep. Perfect. Thank you.
Okay. All right. I apologize. Okay, let's go back. So I would like to, today I want to talk about pleomorphic sarcoma. But first, I want to start with a case presentation. The patient is a 69-year-old woman with a right groin mass. She fell back 2 months prior to presentation, and examination revealed a 3.8 centimeter mass concerning for malignancy. The mass was excised. This was done because the patient had a clinically significant medical history. I'm not going to talk about this history to you right now. I will mention it later on. So examination revealed a multinodular lesion on low power. Close-up examination revealed a mixture of highly pleomorphic cells embedded in a myxostroma. In areas, in addition to the myxostroma and the pleomorphic cell, you can appreciate delicate vasculature. Some areas were more cellular with pronounced nuclear pleomorphism. Most of the cells were spindle-shaped. Occasionally, you could see larger cells. Mitotic figures were increased. Here you can see a couple, including a typical forms. Some cells had the giant cell look to them. Now, I ask the audience, what is your diagnosis? Is this myxoid liposarcoma, myxo-inflammatory fibroblastic sarcoma, Evans tumor, or low-grade fibromyxoid sarcoma? Is this a Myxofibrosarcoma or something else? I'll take a couple seconds to think about this. We're gonna move on. We're gonna revisit this case later. But first, I wanna show you my outline. We're gonna talk about pleomorphic sarcoma. We're gonna see why it's important to subclassify them. We're going to discuss some challenges associated with their classification. And then we're gonna finish with a conclusion. Pleomorphic sarcomas are relatively rare soft tissue malignant neoplasm that commonly affect older men. They're characterized by marked variation of tumor cell nuclei, tumor cell shape and size. More importantly, they're characterized by a widely variable clinical behavior. The next two slides will further emphasize this widely variable clinical behavior. Table one here shows the metastatic potential of a few selected pleomorphic sarcoma. As you can see at the bottom, pleomorphic rhabdomyosarcoma is characterized by a 90% recurrence rate as opposed to differentiated liposarcoma that has a 15 to 20% metastatic potential. Similarly to their metastatic potential, the local recurrence rate is also different. Dedifferentiated liposarcoma has up to 80% local recurrence rate as opposed to undifferentiated pleomorphic sarcoma that has a 20 to 80%. Because of this widely clinical behavior and prognosis, it's very important to subclassify them correctly. To rely on histologic features, shape of tumor cell, are the tumor cell spindle, are they epithelioid, are they round, are they like giant cells? We look at the growth pattern. Are they do we have spindle cell arranged in fascicle? We have a larger cell arranged in sheets. We look at the stroma. Is the stroma collagenous, fibrous? Is it myxoid? Do we have necrosis? And we look at the vascular pattern. Do we have a curvilinear vasculature? Do we have a plexiform vasculature? Or do we have a staghorn vasculature? These are a few examples. Coupled with the morphologic features, we also rely on immunohistochemical stain. Well, immunohistochemical stain, they help with ruling out most common tumor like carcinoma, melanoma, and lymphoma. The immunohistochemical stain are not that specific to diagnose a pleomorphic sarcoma per se. In cases of pleomorphic sarcoma with marginic features, they are really helpful because they can help document smooth muscle differentiation or skeletal muscle differentiation, but for the most part, they help us rule out most common lesion. Molecular studies are helpful too in cases of, especially in cases of dedifferentiated liposarcoma, which is characterized by amplification. And finally, clinical history. Clinical history is very important. If we think we have a pleomorphic sarcoma in a patient with a known history of carcinoma, actually, it would be more helpful to try to rule out carcinoma than to diagnose a sarcoma, because common things are common. The first pleomorphic sarcoma I want to discuss today is Myxofibrosarcoma, the high-grade type. Myxofibrosarcoma is a pleomorphic sarcoma that affects older gentlemen. It usually involves the extremity and trunk as a solid growing subcutaneous mass. By microscopy, on low power, we're going to have a multinodular architecture. The tumor cells are usually spindle-shaped, but one sometimes can see epithelioid form or a pleomorphic giant cell. The stroma is strongly myxoid, as shown here. In addition, these are tumors that are characterized by a very particular vascular network. The vessels have a curve pattern, to which we give the name curvilinear vasculature, shown here in the middle. To diagnose myxofibrosarcoma, one has to have a myxoid stroma that represents more than 20% of the tumor volume. So this has been, there's been a lot of debate regarding the percentage of myxoid stroma to call myxofibrosarcoma. I've seen different numbers in the literature, but I believe 20% is a good compromise. More than 20%, then we can make a diagnosis of myxofibrosarcoma. If one looks carefully, in cases of myxofibrosarcoma, one will see pseudolipoblasts. These are pleomorphic cells with vacuolated cytoplasm. And in the cytoplasm, in the lumen of the cytoplasm, we see myxoid material. This myxoid material is similar to the myxoid material in the background of the tumor, hence the name pseudolipoblast, as opposed to true lipoblasts that have a clear vacuolated cytoplasm. There's no ancillary tests. Ancillary tests are not helpful in diagnosing myxofibrosarcoma. The diagnosis is mostly based on clinical picture and morphology. The differential diagnoses include myxoinflammatory fibroblastic sarcoma, pleomorphic sarcoma, myxoid liposarcoma, and undifferentiated pleomorphic sarcoma. I'm not going to touch on pleomorphic sarcoma and undifferentiated pleomorphic sarcoma right now because I'll discuss this later on. Myxoinflammatory fibroblastic sarcomas are tumors of intermediate malignant potential, usually arising in the extremity. They are characterized also by multinodular architecture and large atypical cells that have a Reed-Sternberg or Varro-like vesicular nuclei. Fortunately, they are characterized by a specific genetic translocation, and there are FISH tests for that targets those translocation. Now, let's go back to our presentation. To refresh your memory, we have a pleomorphic-like tumor characterized by a highly pleomorphic cell embedded in a myxoid stroma. Some vessels have a curved appearance. The majority of the tumor cells have a spindle cell shape. Mitotic figures are increased. So what is your diagnosis? So when I first looked at this case, I thought it was a Myxofibrosarcoma. I was very convinced. Turns out the patient had a history of melanoma that occurred in the same location. She had a resection a while back, and then a few months later, after she fell, a nodule popped up in the same area. So the dermatopathologist, even though I was thinking Myxofibrosarcoma, my colleague dermatopathologist thought this could be melanoma. And he was right. This is an electron microscopic picture of the case. Notice here the melanosome, and here in the middle, we have a pre-melanosome. These findings are consistent with melanoma. So the moral of the story, things are not always what it appears to be. So I've never seen a melanoma with such a myxoid stroma before. So I went and did a search in the literature, and I found this case. There's been a case published about primary myxoid melanoma. So this can happen. And then we went back. Initially, we performed a panel of melanocytic markers. We thought they were negative, and when we went back and we looked at it, we could see focal positivity for SOX10, S100 protein, and melanin. So my point with this case is pleomorphic sarcoma is actually pretty rare. So it's very imperative to rule out most common lesion before we make a diagnosis of sarcoma. I'm not asking the audience to perform electron microscopy on all their cases. No, I'm not doing that. But if the patient has a history of melanoma or a history of carcinoma, it's important that we use all the tools we have to rule that out before we diagnose sarcoma. Next, pleomorphic sarcoma I want to discuss today is dedifferentiated liposarcoma. This is a malignant dedifferentiated lipogenic tumor characterized by MDM2 amplification. They can actually arise de novo or from a well-differentiated liposarcoma. This tumor usually affects middle-aged to elderly adult. Often they arise in the retroperitoneum, followed by the extremity, trunk, and pelvis. In fact, whenever you have an ugly-looking sarcoma in the retroperitoneum, you get a biopsy, it's dedifferentiated liposarcoma until proven otherwise. Dedifferentiated liposarcoma is a biphasic tumor composed of a well-differentiated low-grade lipogenic component and a second non-lipogenic component. The non-lipogenic component usually has an undifferentiated pleomorphic sarcoma-like pattern, but I'm going to show you later that more and more we are noticing that this non-lipogenic component can be low-grade also. In about 10% of cases, one can see heterologous differentiation, like leiomyosarcoma, rhabdomyosarcoma, or stereosarcoma, or angiosarcoma. In a perfect world, this is what you want to have. You want to have a well-differentiated low-grade lipogenic component seen here on the right, and a non-lipogenic high-grade component with a pleomorphic undifferentiated sarcoma pattern. And between the two, you're going to have an abrupt transition. This is in the perfect world. In reality, when you get a biopsy, for example, from the from a retroperitoneal mass, you're just going to have a tiny biopsy, almost always looking like this. So I have a low threshold. Whenever I get a consult or a case, a biopsy, and looks like a ugly looking sarcoma from the retroperitoneum, I do not hesitate. I send it for FISH right away. And almost always it's MDM2 is amplified, and almost always these are the differentiated liposarcoma. This is what the non-lipogenic component look like. Has a non-differentiated pleomorphic sarcoma-like pattern, composed of spindle cell and larger pleomorphic cell with multinucleated giant nuclei. In some cases, the non-lipogenic component will have a heterologous differentiation. Notice the malignant osteoid here. So this would not be an osteosarcoma because this tumor cell will express MDM2. So this is the differentiated liposarcoma. They can also have a myxoid features. This can be reminiscent of myxoid liposarcoma. Again, this cell will express MDM2 amplification by FISH test. And this is an example picture showing MDM2 amplification. When I was a baby, when I was a fellow, we compared the cases of dedifferentiated liposarcoma with low-grade non-lipogenic component and high-grade non-lipogenic component to see if there was a difference between the prognosis. So how did you define low-grade non-lipogenic component? It was defined based on lack of necrosis, lack of pronounced nuclear tepia, and lack of and up to 3 hematotic figure per Harper field. We were able to show that patient with non-lipogenic component that was low grade did better than patient who had a high grade non-lipogenic component. So when I sign out the cases of dedifferentiated liposarcoma, in the comment, I usually mention this, say the non-lipogenic component is usually low grade looking. There's no consensus on this. Some people in the literature, some people don't believe there's such a thing. I think it's a good practice to just document it in the comment. This is an example of one of our cases that was dedifferentiated liposarcoma with a low-grade non-lipogenic component. Notice here the spindle cell proliferation. On close-up, you can see that the nuclei have absent to mild nuclear tepia. There were no evidence of necrosis, and mitotic figures were sparse. The differential diagnosis, especially in the retroperitoneum, you have to think of leiomyosarcoma and malignant peripheral nerve sheath tumor. MPNST, tough diagnosis to make. You have to rely on the clinical history, and you have to be able to show evidence of Schwann cell differentiation either by morphology, by immunohistochemistry, focal positivity for S100 protein, or by electron microscopy. In most cases, the patient will have a history of NF1. I will talk about the leiomyosarcoma, so I'm not going to touch upon it right now. Talk about pleomorphic sarcoma later on too. I'll talk about undifferentiated pleomorphic sarcoma too. More important entity you want to rule out whenever you have an ugly looking spindle cell lesion, it's sarcomatoid carcinoma. In the US, last year we only had about 12 to 13,000 cases of sarcoma as a group. Every year we have a lot of carcinoma, so carcinoma are way more common than sarcoma. So it's imperative to, whenever I have an ugly looking case that I think it's a sarcoma, I usually throw in 1 or 2 keratin markers to rule out sarcomated carcinoma. Especially if the patient has a history of carcinoma, it's very important to rule it out. Next, pleomorphic sarcoma I want to talk about is pleomorphic liposarcoma. This is a very rare tumor that affects older gentlemen. The peak incidence is in the 6th decade. Actually, it's a bit between 6 and 7. Patients are a little older. It has a tendency to affect more men than women. It presents as a large painless mass and usually affect the deep soft tissue of the extremity. The histologic criteria is that pleomorphic liposarcoma is a high-grade sarcoma with a high-grade looking non-lipogenic component admixed with a lipogenic component comprised of pleomorphic lipoblasts. By molecular findings, they are characterized by a complex and non-specific genetic profile. This is an example of a pleomorphic liposarcoma in a 74-year-old man. This tumor arose from the thigh. Notice on low power the nest of tumor cells admixed with multivaculated cells and necrosis. On high power, notice the large cell with multivaculated cytoplasm and highly pleomorphic nuclei. It's very important to be able to see this in order to make the diagnosis. In most tumors, they are plentiful, but in some cases, they are rare. In the background, you can also see mitotic figures. Usually, the non-lipogenic component may cover a wide morphologic spectrum, including fascicular form, myxoid forms, all different kind of histologic pattern. One pattern can be seen in the tumor or multiple patterns can be seen in the tumor. In some cases, an epithelioid variant can also be seen. This epithelioid variant can be tricky sometimes because according to this study, they show that 5 out of 11 cases were focally positive for keratin. And this can cause some trouble, especially if the patient has a history of renal cancer or adrenocortical cancer. This is the same case I showed you earlier. This is a different area of the tumor. Notice the bigger nest or trabeculum of tumor cells. When you go on high power, you can appreciate the epithelioid nature of the tumor cells with nicely delineated cytoplasmic membrane, so increased mitotic figures. You can appreciate the round, enlarged nuclei with vesicular chromatin. Unfortunately, this variant can focally express keratin, which can lead to a big problem. So in the differential diagnosis, one has to always be careful and make sure to rule out primary metastatic tumor, especially because of the multivaculation of the lipogenic component, the lipoblast. This tumor can mimic an adrenocortical neoplasm. So it's very important to use inhibin, melanase, PAX8, and a lot of keratin marker to rule out either a tumor coming from the adrenal gland or the kidney. It's very important to rule out melanoma too. And because of the presence of the pleomorphic lipoblast, one has to make sure to rule out the differentiated liposarcoma. Unlike the differentiated liposarcoma, this pleomorphic lipoblast will not show MDM2 amplification. And so this is very important. Pleomorphic liposarcoma does not have a specific genetic profile. Very helpful in diagnosis. Next two cases I'll talk about are pleomorphic sarcoma with myogenic features. In these two cases, it's the use of immunohistochemical staining is important because they will help us prove either smooth muscle differentiation or skeletal muscle differentiation. First, I'll talk about pleomorphic leiomyosarcoma and then pleomorphic rhabdomyosarcoma. Leiomyosarcoma are smooth muscle malignant neoplasm with smooth muscle differentiation. Less than 10% of leiomyosarcoma will be classified as pleomorphic leiomyosarcoma. Now, I'm using the term pleomorphic leiomyosarcoma. Some people may say leiomyosarcoma with polydifferentiated area or leiomyosarcoma with area of dedifferentiation. I believe we're talking about the same thing. These are tumors that will affect older individuals. They will arise in the soft tissue of the extremity and retroperitoneum. And a little bit of trivia. This is the most common soft tissue tumor to metastasize to the skin. The criteria for diagnosis is pretty straightforward. Pleomorphic leiomyosarcoma is characterized by multinucleated bizarre giant cell, sometimes epithelioid cells, admixed with conventional spindle cell showing conventional smooth muscle features with elongated, blunted end nuclei and pink eosinophilic cytoplasm arranged in a fascicular pattern, an interlacing fascicular pattern. And as a criteria, we need to show smooth muscle differentiation. And this can be done by conventional microscopy or with the use of immunohistochemical stain, H-Cal desmin, and smooth muscle actin. One needs to be careful, however. Cal-desmin and desmin can also be positive in GIST, so they are not 100% absolutely specific. One still needs to have the morphology features that will fit in order to make the diagnosis. These are pictures showing pleomorphic leiomyosarcoma. Notice the highly pleomorphic giant cell and spindle cell with elongated nuclei and eosinophilic cytoplasm. Here they are forming fascicle, interlacing fascicle. The pleomorphism can be striking. One can see a giant cell with multi-lobated nuclei. Mitotic figures are usually increased, including a typical form here. Notice the pleomorphic nuclei. This nuclei is actually grade 5 of 3, I believe. Differential diagnosis, again, carcinoma. The unfortunate thing is that pleomorphic leiomyosarcoma can have foci looking like foci that will have epithelioid features. And this can really mimic carcinoma. Coupled with that, they can focally express keratin. So it's very imperative that we throw in not just one keratin marker, but a couple of keratin markers to make sure we rule out carcinoma before we make a diagnosis of leiomyosarcoma. Next, I'll talk about pleomorphic rhabdomyosarcoma, so I'm not going to touch upon this. Sarcomatoid mesothelioma is also very important to rule it out using mesothelial marker. And one always has to rule out melanoma because melanoma can look like anything. Pleomorphic sarcoma. This is, fortunately, this is a rare sarcoma. This type of sarcoma, pleomorphic sarcoma, is actually associated with one of the worst prognosis. Usually affects elderly men, more men than women. It's a type of sarcoma that usually present as a deep soft tissue tumors of the lower extremity. They can present with pain, discomfort, but sometimes they present with no pain at all, just as a deep-seated mass. The differential criteria are highly pleomorphic proliferation, having a undifferentiated pleomorphic-like pattern characterized by large atypical cell with abundant pink eosinophilic cytoplasm. Nuclei can be prominent. Mitotic figures are increased, including a typical form, and area for necrosis are usually common. Very important for the diagnosis criteria, one is to show skeletal muscle differentiation. To accomplish this, we need either myogenin or MyoD1 positivity. Can rarely be diffuse. Usually it's focal. If one can document focal positivity for either one of these immunostain, then the diagnosis can be made. They can express keratin focally. This is an example of a pleomorphic rhabdomyosarcoma arising in the thigh of an 84-year-old man. Notice the sheets of highly pleomorphic cells, giant cell with pink eosinophilic cytoplasm. Close up, the cells are highly pleomorphic, some are spindle shaped, some are large, the nuclei are highly abnormal. Desmin was strongly positive, and MyoD1 show focal positivity. This is another example of pleomorphic rhabdomyosarcoma showing highly pleomorphic cell with abundant pink eosinophilic cytoplasm, highly giant multinucleated giant cell here. In this picture, you can see that myogenin is focally positive. So this is usually what happens. Desmin can be strong, can be focal, but most of the time, myogenin or MyoD1 will show some focal positivity. And this is enough to make the diagnosis. Pleomorphic rhabdomyosarcoma have a genetic profile similar to undifferentiated pleomorphic sarcoma, but unlike undifferentiated pleomorphic sarcoma, they are characterized by a worse prognosis, higher rate of metastatic potential, and higher rate of recurrence. And unlike undifferentiated pleomorphic sarcoma, they do not express myogenic differentiation. Differential diagnoses include, again, sarcomatoid carcinoma, malignant peripheral nerve sheath tumor, and dedifferentiated liposarcoma. I mentioned that dedifferentiated liposarcoma can have heterologous differentiation in about 10% of cases. 10% of these cases might show positivity for desmin or myogenin or MyoD1. But unlike pleomorphic rhabdomyosarcoma, the differentiated liposarcoma cell will show MDM2 amplification. So MDM2 can be very helpful in the differential diagnosis. And this is the last case I want to talk about, last pleomorphic sarcoma I want to talk about today, undifferentiated pleomorphic sarcoma. This is the most common soft tissue sarcoma, represent between 15 to 20% of tumor. Implied in the name, these tumors will show no line of differentiation. They usually arise in the extremity and trunk of older adults. It's more common in men than women. They can be triggered by prior radiation therapy. In some patients with lymphomany, they can arise also. Undifferentiated pleomorphic sarcoma is characterized by several architectural patterns. Can be storiform, fascicular, or this tumor cell can be arranged in sheet. Whenever I have an ugly-looking sarcoma with a storiform architecture, first thing that comes to mind is undifferentiated pleomorphic sarcoma, especially if these tumor cells are ugly-looking and the immunostains are all negative. I strongly think about UPS. The stroma is variable. It can be myxoid, it can be hyaline, it can be fibrous. Now you're gonna ask me, well, how do you differentiate between UPS and Myxofibrosarcoma? Well, we have our cutoff for myxoid stroma volume. Usually in UPS, the myxoid stroma will not be more than 20%. One should not be able to see curvilinear vessel, and the clinical picture is also different. Undifferentiated pleomorphic sarcoma characterized by high-grade pleomorphic cell. They can be spindle. We think of UPS as having spindle cell, but not just spindle cell. They can have epithelial cell, or they can have a multinucleated cell also. This is a case of UPS. Notice the storiform pattern at medium power. When one goes higher, one close-up imaging can show pleomorphic cells on large nuclei, atypical mammary figures. And very importantly, UPS, like implied in the name, shows no line of differentiation. So if you perform a panel of immunohistochemical staining, they should be negative. In fact, UPS is a diagnosis of exclusion. We have to rule out all the mimickers. We have to make sure it's not, if it's a retroperitoneum, we have to make sure it's not the differential liposarcoma. If it's extremity, superficial soft tissue, we have to make sure it's not a metastatic sarcomatoid carcinoma. Like pleomorphic rhabdomyosarcoma, they're characterized by a complex genetic profile. Differential diagnosis, especially if the patient has a history of visceral carcinoma, you want to rule out sarcomatoid carcinoma. If it's around the large joint, you want to rule out tenosynovial giant cell tumor, which is a benign lesion. In the retroperitoneum, we want to rule out the differentiated liposarcoma. MDM2 is a very powerful tool. And if one can see osteoid matrix, we have to rule out extraskeletal osteosarcoma. And melanoma should always be ruled out because melanoma can look like anything. This is a table that I hope will be helpful to you guys. Shows the different subtype of selected pleomorphic sarcoma with the frequency, clinical finding, key histologic finding, immunohistochemistry, and molecular finding. As you can see, the majority of them are characterized by complex karyotype. Only the differentiated liposarcoma is characterized by MDM2 amplification. This is what I use in my practice. These are panels that I use when I'm faced with a spindle cell tumor soft tissue or round cell tumor soft tissue. I always throw in one or multiple keratin marker to rule out carcinoma first and foremost. I sometimes I throw in melanoma markers too. And fish, we have available fish probe that we use sometimes also. So in summary, pleomorphic sarcoma are rare soft tissue tumor that can mimic carcinoma and melanoma. They are characterized by a widely different clinical behavior. So subclassifying them is very important because they don't have the same prognosis. To classify them, we rely on morphologic features and on specific morphologic features and use of ancillary tests for accurate diagnosis. This is my last slide. And I'm open for questions. Thank you.
Okay, thank you so much for that excellent presentation, Dr. Dante. It was awesome.
Thank you.
The only question I have in here so far is, what is the basic panel of IHC you perform on core biopsies of a pleomorphic sarcoma? So I guess if you have very limited tissue, what should you do first?
Pleomorphic sarcoma, it depends. Based on the location, if it's the retroperitoneum, I have minimal amount of tissue. I'm targeting dedifferentiated liposarcoma. So in our laboratory, we need foreign stain. I will send those foreign stain to the fish lab right away if I have minimal amount of tissue. If you don't have access to fish, are there IHC stains you would recommend? Well, some people use there's a stain for MDM2. We don't have it. We ban it in our lab because it's not entirely specific or sensitive. But it works sometimes. So if you can get your hands on it, you should probably get it in your lab.
Okay.
And also, you also want to rule out melanoma. Well, you have to throw in pen-cytokeratin. Very important. You want to rule out carcinoma. They are more common than anything else. So.
And we just got one more question.
Right. Do
you use SATB2 to determine osteogenic differentiation for undifferentiated looking tumors?
No, we don't. I don't use it. I know a lot of people do. We don't have it in our lab. For sarcoma, osteosarcoma diagnosis, I rely on morphology.
Great. If anybody else, let's see, does anybody else have any more questions? Hold on, let me see. We don't have any more questions. So in that case, I want to thank everyone who was on here. Thank you, Dr. Dante. And again, here's the CME information for everyone. And all of the recordings will be available once we finish the series. So for anyone who was looking for the previous lecture by Dr. Matoso, or if you're looking for Dr. Dante's lecture, they will be available after the series. And with those lectures will also be some CME questions so that you can get your CME credit and your SAM credit. Thank you, everyone.
Thank you, Dr. Schwartz, and thanks to the PAP.
One more question.
Sure.
Do you ever see focal positivity for pan-CK in pleomorphic sarcomas?
Yes, it has been described. Yes, you can see it. It should be focal, not diffuse. Yes.
Okay, I have entered that answer.
Right.
All right, well, thank you so much.
Thank you.
And we'll see everybody next time.
Thanks to the PAP again. Thanks, Jessica. And thanks, Jason.